Thank you, Pranjali. Kind words of introduction. It's always a pleasure to be here at DGenius because it's like an alumni association of our center because I get to catch up with all my old students and sometimes it makes me feel positively ancient as well. But so, can I have my slides? I don't think this is my presentation. Not my presentation. So I've been asked to talk about a very interesting aspect of diabetology, that is precision diabetes. So I have no conflicts of interest relevant to this talk. And the whole concept of precision diabetology comes from this aspect. Today when we started the session, Ninad very kindly gave me these waistcoats. But first thing he asked me was, what's your shirt size, sir? I said my shirt size is 40. So, okay, you need a 42 size waistcoat. Please note that you didn't keep the same size waistcoat for all the faculty because we are all of different sizes. So in life as well as in medicine, one size does not fit all. And that's where this concept of precision medicine came. What's precision medicine? Nothing but providing the right therapy for the right patient at the right time. And there is another term known as personalized medicine, which is related to precision medicine, but probably a slightly more expanded version of that. Precision medicine decides the treatment for a patient based on science. For example, response to therapy based on the genetic background of the patient, environment of the patient, and so on. But suppose a patient cannot take the precise treatment for various reasons. Either the patient is not able to afford the treatment or they just don't want to take it. The clinician has to bear that in mind while deciding therapy for that particular patient. So, personalized medicine is nothing but precision medicine, which also takes into context the patient preferences and the social background of the patient. So how does this apply to diabetes? Precision medicine has been applied for a long time, much longer than you think. Probably the earliest example of precision medicine I can think of is in blood transfusion. We don't give the same blood to everyone, isn't it? You type the blood, cross match the blood, and only give the matched blood. But it's only recently that the concept of precision medicine has become important in diabetes. And probably the first step towards this was taken by the ADA and the EASD when they published this consensus statement about precision medicine in the year 2020. Subsequently, another paper was published in the year 2022 in which they further expanded this vision and tried to incorporate various types of diabetes, the diagnostic criteria, the screening criteria, the treatment pattern, as well as the prevention. And it's a matter of pride to us that Professor Mohan was part of this group as a representative of India. And just last year, a couple of years ago, the Nature Medicine, the second consensus report on precision medicine has been published, which concentrates on the gaps and opportunities when applying the precision approach to management of diabetes. So briefly, I'll talk about the precision approaches to pre-diabetes, type 1 diabetes, type 2 diabetes, and most importantly, monogenic diabetes. In the interest of time, I will not go into the further details of other types of diabetes. So how does the precision approach help in pre-diabetes? The two common forms of pre-diabetes, we know, impaired glucose tolerance, impaired fasting glucose, are not similar. They are not identical. They differ in pathophysiology, natural history, and response to the intervention. For example, impaired glucose tolerance, which is the most common form of pre-diabetes across the world except in these parts, except in Southeast Asia, is characterized by reduced insulin sensitivity in the skeletal muscle, but preserved sensitivity in the liver, and there is a decrease in both the first and second phase insulin secretion. They have a high risk of progressing to type 2 diabetes, but they do respond well to interventions such as lifestyle modifications, diet, exercise, weight loss, and even metformin. IFG, on the other hand, which is the most common form of prediabetes in India and the rest of Southeast Asia, is characterized by normal skeletal muscle insulin sensitivity, reduced hepatic insulin sensitivity, effective first but not second phase insulin secretion. It has a lower risk of progression to type 2 diabetes, but those who do progress, there is very little we can do with the current level of information to prevent these people from developing diabetes. Taking it further, a Central European group has done this study looking at various clusters of prediabetes. We talked about the clusters of type 2 diabetes. Now we have clusters of prediabetes based on insulin secretion, insulin resistance, fat distribution, etc. And they identified 6 clusters, 3 of whom were found to be high-risk clusters. 2 of these had high risk of progressing to diabetes. Third group did not have a high risk of progressing to diabetes, but they had a higher risk of developing complications such as nephropathy and a higher risk of dying. So what's important here is that if you can differentiate people with pre-diabetes based on this, you can target interventions to those people who are more likely to progress to diabetes, number one, and number two, to develop complications. What about type 2 diabetes? Praveen has already mentioned about the clustering approach. This is the original clustering approach which was done in the Scandinavian population. And we now know that in India, there are two novel clusters of type 2 diabetes, the IROD and the CIRDD. Already Praveen has described these clusters quite lucidly. And he has also mentioned that they differ in their ease of attaining glycemic target, risk of complications, and there is a tantalizing prospect which is not proven yet that they may respond differentially to anti-diabetic therapy. Studies are underway to find out if this is indeed true. But we are already following a precision approach in treating type 2 diabetes. Ancient people like me remember these guidelines. And I know that some of the senior people in the audience may know this is the 2017 ADA guidelines. See the first treatment for type 2 diabetes, metformin, metformin, metformin. Look at the current guidelines. Metformin is there, yes. But now you have SGLT2 inhibitor, GLP-1 receptor agonist, all that sort of thing for people who have got specific phenotypic characteristics, ASCVD, CKD, and congestive heart failure. So we are already following some form of precision medicine in treating type 2 diabetes. All that is now needed is further refinement to apply it to the other patients who are the garden variety of type 2 diabetes without any of these compelling indications. Type 1 diabetes, the application is relatively limited. We know that type 1 diabetes varies in whether they are antibody positive or antibody negative and the number of antibodies they may have and whether they continue to have some degree of residual beta cell function or not. And this is the staging of type 1 diabetes as per the ADA guidelines. And now we know that there are treatments that are available which can be applied at each of these stages of diabetes. Epluzumab, the monoclonal antibody, has already been approved for prevention of type 1 diabetes in those with preclinical type 1 diabetes, and other treatments such as baricitinib and verapamil are also in the pipeline but not yet approved by the US FDA. So based on the subtype of type 1 diabetes, you may in future be able to design targeted or precision therapies for this form of diabetes. Finally, I'll talk about what is known as the poster child of precision diabetes, that is monogenic diabetes. This is diabetes caused by mutation in a single gene. Around 80 genes which have been identified as causal for monogenic diabetes, of which these 4 phenotypes may be of interest to us when you are talking about precision diabetes. The first is neonatal diabetes, that is diabetes occurring in children less than 1 year of age. And these are the common mutations KCNJ11, ABCC8 and the insulin gene. The KCNJ11 and ABCC8 mutations usually respond to high dose sulfonylureas. The insulin gene mutations need insulin. The glucokinase MODY or MODY2, maturity onset diabetes of the young, type 2, the mild hyperglycemia caused by defective glucose sensing in the beta cell, and these people can be taken off treatment unless they are pregnant. The transcription factor MODY is HNF1 alpha, HNF4 alpha. They respond very well to low dose sulfonylurea, and those of them who have been mistakenly diagnosed as type 1 diabetes, you can actually shift them from insulin to sulfonylurea. In the syndromic forms of diabetes, so many syndromes are there. Mostly they need insulin, except this peculiar form of diabetes known as thiamine responsive megaloblastic anemia or Rogers syndrome, which responds to high dose thiamine. So this is an example of precision medicine in neonatal diabetes, not an RCT, but just to show you the effect of changing treatment based on precision medicine from insulin to sulfonylurea in these children. See the decrease in HbA1c that you get, 14 to 7, 16 to 6. These were children who are not controlled with insulin. And giving sulfonylurea, they were able to get near normoglycemia. And not only that, the normoglycemia seems to persist. It is a durable form of treatment for these children, both in KCNJ11 and ABCC8 variants. The converse of it is that if you stop precision treatment in somebody who has been following precision treatment, you end up causing deterioration of glycemic control. This is a patient with MODY3 from Dr. Hattersley's group who was doing very well on sulfonylurea. Then she was worried about weight gain, so she shifted over to metformin and see what happened to the HbA1c. It was 3 years before wiser counsel prevailed and she was put back on sulfonylurea and she responded just as she was doing earlier. So this is a child with neonatal diabetes who was diagnosed at our center. She is now, I think, 11 or 12 years old, if I'm not mistaken. She continues to do well with sulfonylurea, just to show the sort of savings that you can get if you make a diagnosis. This is the sort of money that she would have to spend on insulin. 2,58,000. She has saved around 2.5 lakh rupees just by this precision diagnosis. And that is not to mention the psychological difference when you take tablets when compared to insulin, which cannot be measured in rupees. A change in the life of the patient. If genetic testing was not done, she would still have been on insulin. So I'd like to conclude by saying that the precision approach to medicine has now reached a diabetes clinic. Its firm foothold is in the stage of monogenic diabetes. The other forms of diabetes still aspirational, but getting there. But we need future research to see whether precision approaches can be used in cost-effective manner. And we don't want to increase health disparities by making all treatment decisions based on costly tests or investigations which most people cannot afford. So that is going to be the challenge going forward in precision medicine. I thank you for your attention.